So thanks for bearing with me. We're on the last section of the video. So in this one we're going to talk about some clinical uses, specific agents, and side effects toxicities. So let's start with some clinical uses. There are so many uses of local anesthetic in our modern practice of anesthesia. They all take advantage of the ability of local anesthetics to block the pain and other nausea stimulation. As topical agents like Embla cream, they can help with IV insertion, especially in kids. In the awake patient, we can use aerosolite benzocaine or viscous lidocaine on the mucosal surfaces to help blunt the respiratory reflexes when we're instrumenting the airway. IV lidocaine can decrease the pain on injection of propofol and also blunt the hemodynamic response to intubation or extubation. But by far the most common application of these local agents, local anesthetics, is the local infiltration. So used for superficial procedures, suturing, etc. We use local anesthetics in veer blocks, nerve blocks, centrally near the nerve roots, either intrathecally in the lumbar cistern or epidurally. Now, in the next section, we're going to talk about some of the specific agents we use every day. Let's start with esters. Chloroprocaine initially gained popularity as an epidural anesthetic because, especially in the obstetrics, because its rapid hydrolysis virtually eliminated concerns about systemic toxicity and fetal exposure to the local anesthetic. Unfortunately, neurotoxic injury presumed to occur from the accidental intrathecal injection, especially with high doses, and this tempered enthusiasm for neuraxial administration of chloroprocaine. Some early experimental studies, really attributed this to the preservatives, the sodium bisulfite that was in the commercial formulation at the time. But there is no evidence that the use of preservative-free chloroprocaine is associated with bad outcomes. Chloroprocaine produces epidural anesthesia of a relatively short duration, but with rapid onset. But when you use epidural chloroprocaine, it impairs the anesthetic or analgesic action of epidural bupivacaine and opioids used concurrently or subsequently. So plan accordingly. Next is the amide local anesthetic. Lidocaine is the most commonly used local anesthetic in the world. It's used for local, topical, and regional IV applications, peripheral nerve block, spinal, and epidural anesthesia. Potential neurotoxicity like cauda-equina syndrome and lidocaine is administered for spinal anesthesia. It is a real concern, especially when used with continuous spinal techniques. Transient neurologic syndrome, TNS, is a syndrome of pain and dysesthesia that can occur in up to about a third of patients getting intrathecal lidocaine. But it can but rarely occur with bupivacaine. These symptoms were initially called transient radicular irritation, but this term was later changed or abandoned because we don't really know why it happened. We can't just call it radicular. Although self-limited, the pain can be quite severe and often worse than the surgical pain, and on rare occasions requiring rehospitalization for pain control. Now, we use bupivacaine all the time. Long duration of action combined with its high quality sensory anesthesia relative to motor blockade has made it one of the most commonly used local anesthetic for epidural, during the labor, and for post-op pain management. It's also commonly used for peripheral nerve blocks and spinal anesthetics, as you can imagine. The most likely mechanism for bupivacaine's cardiac toxicity relates to the nature of its interaction with cardiac sodium-ion channels. When electrophysiologic differences between the anesthetics are compared, lidocaine is found to enter the sodium-ion channels quickly and leave quickly. In contrast, recovery from bupivacaine blockade during diastole is relatively prolonged, making it far more potent with respect to depressing the maximum upstroke velocity of the cardiac action potential in ventricular myocyte. So, bupivacaine has been labeled a fast-in, slow-out local anesthetic. Remember, lidocaine was fast-in, fast-out. This characteristic likely creates conditions favorable for unidirectional block and re-entry on the cardiac myocyte. Now, Other mechanisms may contribute to bupivacain's cardiotoxicity, like disruption of the AV nodal conduction, depression of myocardial contractility, and indirect effects mediated by the central nervous system. This potential for cardiotoxicity places important limitation on the total dose of bupivacaine that you can give, and it underscores the important role of fractional dosing and methods to detect inadvertent intravascular injection during high volume regional blocks. The identification of lipid emulsion as a therapeutic intervention for bupivacaine cardiac toxicity does not diminish the critical importance of these preventative measures. Of note, cardiotoxicity is of no concern when small doses are administered for spinal anesthesia or local infiltration, as you can imagine. Here you can see the three commonly used local anesthetics. Bupivacaine can be used for local infiltration, peripheral nerve block, epidural, or spinal anesthesia. Now, for local infiltration, it has a fast onset and lasts about 2 to 8 hours. For peripheral nerve blocks and epidural, it has a slow onset, about 30 minutes, and long duration. This is when you have to think about the maximal dosing of 2.5 to 3 mg per kilo because of the higher volumes needed. For spinal anesthesia, it has fast onset in minutes and lasts about 2 to 3 hours, depending on the dose. Next agent is lidocaine that can be used for local infiltration, peripheral blocks, epidural, or spinal, but also topically as well as IV regional anesthesia. It has a fast onset, but of low to intermediate duration. Lastly, chlorprocaine is primarily used for urgent labor epidural anesthesia for cesarean delivery with the onset of 10 to 15 minutes, and spinal anesthesia for procedures lasting less than 45 minutes or 30 minutes in my experience. Now, in the concluding section, we're going to briefly talk about toxicity and treatments of toxicity. Local anesthetics readily cross the blood-brain barrier, so we can see CNS toxicity pretty quickly with systemic absorption or inadvertent IV injection. The effects on CNS are determined by the plasma concentration of the local anesthetics, because that's how they get there, and that's where the concentration gradient is. At low plasma concentration, we see mild disturbances to the sensory system, like ringing in the ears, etc. And you can ask the patient with lidocaine testers. As the plasma concentration goes up, CNS excitation and seizure activity happens. If the plasma concentration keeps going up and is large enough, the increase is rapid, we can get the CNS excitation progress into generalized CNS depression and coma, and this leads to respiratory depression and cardiovascular collapse, arrest. At the least, local anesthetics are anesthetics and stop propagation of action potential. Brain, action potential, cardiac myocyte, action potential, they will stop them. The potential for CNS toxicity correlates directly with the potency of the local anesthetics. Highly potent lipid-soluble agents, like bupivacaine, can cause CNS toxicity at doses that are a fraction of those of less potent agents. The potential for CNS toxicity is also affected by other factors. For example, a decrease in protein binding and clearance of local anesthetics, systemic acidosis, hypercapnia, and hypercarbia can all increase the risk of CNS toxicity. On the other hand, co-administration of CNS depressant agents like propofol or benzodiazepine can decrease the likelihood for seizures. In general, systemic cardiovascular toxicity is seen at plasma concentrations much higher than that for CNS toxicity. The potential for cardiovascular toxicity, like that for CNS toxicity, correlates closely with the potency or lipid solubility of the local anesthetic. But although all local anesthetic can cause hypotension, dysrhythmias, and myocardial depression, the more potent agents like bupivacaine and ropivacaine are predisposed to the worst outcomes, like fatal cardiovascular collapse. Among the potent long-acting agents, ropivacaine probably has a safer cardiovascular toxicity profile than bupivacaine. Interestingly, the propyl side chain of the ropivacaine is thought to be the reason it is less cardiodepressive than the larger butyl side chain of the bupivacaine. But keep in mind that the underlying pathophysiology responsible for local anesthetic-induced cardiovascular collapse has not been entirely established. Local anesthetic can directly cause major disturbances to the heart, but their effect on the components of the cardiovascular system may be just as important. For example, systemic bupivacaine has been shown to impair regulation by the CNS of the cardiovascular system, disruption to the arterial barrel reflex in the brainstem by bupivacaine can lead to attenuation of the heart rhythm response to changes in blood pressure. Local anesthetic also act on the smooth muscle endothelium surrounding the blood vessel. In the periphery, the vasoconstriction occurs at subclinical doses and vasodilation at higher doses, as we talked about before. Now, interestingly, in the pulmonary vasculature, increasing local anesthetic concentration produces a marked pulmonary artery hypertension. The increase in the pulmonary vascular resistance occurs before any changes or any decrease in the cardiac output. So this makes it a primary effect of the local anesthetic intoxication and not really secondary to drop in cardiac contractility. Elevated concentration of the local anesthetics delay cardiac electrical conduction and decrease cardiac contractility. Although all local anesthetic disturb the cardiac conduction system via a dose-dependent block of sodium channels, because they can all prolong the PR interval and the QRS complex, there are several features unique to bupivacaine that seems to make the cardiovascular toxicity worse. First, bupivacaine has an inherent greater affinity for binding resting and inactivated sodium channels than lidocaine. Second, although all local anesthetic bind sodium channels during cardiac systole and dissociate during diastole, the dissociation of bupivacaine during diastole is much slower than lidocaine. The slow rate of dissociation prevents a complete recovery of the channels at the end of each cardiac cycle, so we can get an accumulation and worsening of the conduction defects. Now, in contrast, lidocaine fully dissociates from sodium channel during diastole, and little accumulation of the conduction delay occur. Remember, lidocaine was fast in, fast out. Bupivacaine is fast in, slow out. Finally, bupivacaine exerts a greater degree of direct myocardial depression than the less potent agents. Here you can see what happens with increasing plasma concentration of lidocaine. Now, at lower concentration, you have analgesia, then we get lightheadedness, tinnitus, kind of like a mild CNS symptoms, then we get the seizures, coma, and finally at much higher doses we get cardiovascular collapse. Now, the best practice for managing systemic local anesthetic toxicity starts with prevention and really vigilance. We can reduce the risk for intravascular injection by using the test dose, aspirating frequently so there's no blood coming back, and also dividing the dose of the local anesthetic so we don't inject the whole thing at once. Heart rate and rhythm, blood pressure, and oxygenation should be monitored at all times. Early CNS toxicity can be manifested by tinnitus or excessive sedation, especially with lidocaine. Not necessarily true with bupivacaine. The treatment of suspected systemic local anesthetic toxicity is really supportive. Now, get intralipid in as fast as you can. Call for help, of course. But we need to stop the injection of local anesthetic immediately, so take the needle out. Oxygenation and ventilation should be maintained, and the airway, if necessary, must be secure. So ABCs of airway. This is necessary not only as a standard part of your resuscitation, but also it prevents further exacerbation of local anesthetic toxicity by hypoxemia, hypercarbia, and acidemia. Now, in many cases, with proper airway management and reversal of acidosis, more serious complication of local anesthetic intoxication can be avoided, especially in cases involving lidocaine or less potent agents. Local anesthetic-induced seizure activity can vastly increase the body's metabolism, and the resultant metabolic acidosis may make resuscitation far more challenging. Now, prolonged seizure activity should be treated with benzos like midazolam or diazepam. propofol may not be the best drug for terminating these local anesthetic-induced seizures because of their depression of the cardiovascular system. Now, if seizures are refractory, we can think about using paralytic to disrupt the muscular activity and reduce the metabolic demand, but this should be the last resort because it does nothing to treat the brain activity that causes the seizure. It only reduces the muscular activity and the metabolic consequence of that. Now, mild myocardial depression and systemic vasodilation can be corrected by sympathomimetic agents, but never delay ACLS. If it's an ACLS situation, use ACLS drugs. And emergent cardiopulmonary bypass is our absolute backup when all fails. Now, this is the first practice advisory in treatment of local anesthetic systemic toxicity. Feel free to read through it, but it hasn't changed much. Essentially, you give a 20% lipid emulsion, a bolus, infusion, and repeat it if needed. So, how does lipid resuscitation work? Let's say you gave a big dose of bupivacaine to a patient and he sees it. You know the next thing is cardiovascular collapse. So while you're doing your ABCs, you call for interlipid. So what is lipid sink? It's the non-specific extraction of the local anesthetic from aqueous, plasma, or cardiac tissue down the concentration gradient into the lipid droplet. Now remember, at time 0, when you just did your injection, the concentration of local anesthetic in the lipid is 0. So the way the lipid reverses local anesthetic toxicity may be increasing its clearance from cardiac tissue down the concentration gradient. Now, another possible mechanism is that lipids counteract local anesthetic inhibition of the myocardial fatty acid oxidation. So they reverse cardiac depression by restoring energy production. Now, in terms of Cauda-Equina syndrome, it is a rare complication of spinal anesthesia, usually with lidocaine. It's usually manifested as prolonged neurologic injury with both sensory and motor components. Again, remember, sensory and motor component. The risk factors include the use of preservatives, use of high concentration of chloroporcaine or lidocaine, and use of microcatheters for continuous spinal infusions, probably because the catheters allow a high concentration of the lidocaine or chloroporcaine to accumulate near the sacral nerve roots. Now, historically, preservatives or other contaminants injected with lidocaine were blamed, but neurotoxicity has been seen following the injection of high concentration of both chloroporcaine and lidocaine. Now, this is independent of the preservatives used. TNS. This is the reason lidocaine is rarely used in spinal injection, and if you're working with me, we're not going to use lidocaine in the spinal fluid. TNS manifests with severe pain, radiating down both legs, which is temporary, but can last hours, days, or rarely weeks. There is no motor component to this. Now remember, Cauda-Equina, yes motor, TNS, no motor. Risk factors include surgical position, specifically lithotomy, early ambulation after spinal, and obesity. This poses a special problem when spinal anesthesia is chosen for short procedure because there are few alternatives for outpatient regional anesthesia. Methemoglobinemia. Prilocaine is the main ingredient in common spray used to treat sore throat. Prilocaine is metabolized in the liver to O-toluene, which oxidizes hemoglobin to methemoglobin, and we generally need high doses to get clinically significant methemoglobinemia, usually more than 600 milligrams. When you have methemoglobinemia, based on the way our pulse ox works and the absorption of light by methemoglobin, the pulse ox reads 84% to 86%, no matter what the true saturation is. When it happens, we can treat it with methylene blue, about 1 milligram per kiloliter dose, and that reduces the hemoglobin back to non-methemoglobin. What about real allergic reactions? True allergic reactions to local anesthetics are rare, and only about 1% of all adverse reactions to local anesthetics are caused by allergic mechanisms. The most adverse responses attributed to the allergic reactions are really due to additives or manifestation of systemic toxicity from excessive plasma concentration of the local anesthetic. For example, hypotension associated with syncope may be a psychogenic or vaguely mediated reaction. Or tachycardia and palpitations may be from systemic absorption of epinephrine that was mixed with local that happened to be injected in the vicinity of the vessel or into a vessel. That seems to happen to me every time I go to my dentist. Now, what about cross-sensitivity? The ester local anesthetic produce metabolites related to PABA or para-aminobenzoic acids, so the more likely to cause hypersensitivity reaction than the amides. Cross-sensitivity does not exist between classes of local anesthetics, though. So if somebody is allergic to esters, they're not allergic to amides. But allergic reaction may be caused by a methylparaban or similar compounds that resemble PABA, which are used as preservative in commercial formulation of both esters and amide local anesthetics. So it is not likely to be allergic to both an ester or amide, but if you have an allergic reaction to both of them, it is likely that it is to the preservatives. That concludes this presentation.